have our host Virtua talking about their journey, which has really been very exciting. And they form a really great case study for what we're talking about today. So I'm going to introduce the two key people from Virtua, and after that it will be followed by panel discussions with team members from Virtua, and then the tour. So I'd like to welcome Ninfa Saunders. She's the Executive Vice President and COO of Health Services at Virtua Health. She's responsible for all healthcare operations throughout Virtua's 4 hospitals, 2 rehab centers, senior services, home care, ambulatory, and outpatient services. Dr. Saunders brings more than 30 years of clinical nursing and hospital administrative experience to this position. Also speaking with her is Michael Kotzen. He is the Vice President and Chief Operating Officer at Virtua Voorhees. As the Vice President of Virtua Voorhees, Michael Kotzen is responsible for supporting Virtua's mission to provide a world-class patient experience through the operation of the hospital inpatient, outpatient, and emergency services and community outreach. He's also the person who's been responsible right from the inception all the way to bringing this hospital to fruition and transitioning here. So I'd like to welcome Mike and Ninfa.
Thank you so much, and welcome to Virtua. So my role this morning is to kind of take you to the Virtua experience and then try to connect the science, the art, and the intuitive sense of everything we've done here at Virtua. So I'll take you through a couple of slides, then Mike will go through the actual happenings or the technical components of what we've done in this hospital. So everything begins and ends with the star at Virtua. So this is something that we talk about all the time, but many of you have pillars, many of you have stars. We have the star, which has 5 points. It's pretty much self-explanatory. Everything that we do, any report out that we have going on at Virtua evolves around those 5 components. This is who we are. If you look at Virtua today, looking at our primary and secondary service area, we have 4 acute care hospitals. We closed a hospital in Camden that would have been the 5th hospital. Today, that is an ambulatory surgery, an ambulatory center that has a great emergency room. We have 2 major outpatient centers, both in Camden, Washington Township. We will now open in about a year, I believe, the ambulatory side of Voorhees, and we are in the process of building Morristown, which is in the northern part of the county. We have 2 long-term facilities, 2 home health services, 5 ambulatory surgery centers that will soon become 7. Most of this are partnership with physicians, where we own 51% and they own 49%. Clinical governance is about 100%. We have 2 health fitness centers, 1 in Voorhees, 1 in Washington Township, and we're building 1 over at Morristown. I think it's important to kind of see how this fits into the bigger picture in terms of our facilities. In looking at what we need to design for this particular community, it was important for us to look at not only the hospital itself, right here, but also the adjacencies related to ambulatory centers, both at Morristown, Voorhees, and Washington Township. Just a little bit of a story when we started looking at this about 2003, I believe. When we started looking at building what would have been about about $800 million in facility, we were very clear at that time that things were changing, that inpatient was not going to be the center of everything that we did. Instead, there will be a migration to ambulatory. Now, that was really quite a jump for us because we did not have the data to show that that would be the case. Today, under healthcare reform, that seems to be predictive in many ways, because we are now beginning to shift under the systems of care. If you look at a curve where hospital is in the middle and community-based is on one end and post-acute is on the other end, we're beginning to see a shift or trying to push towards community-based. Virtua Health today has about 8,400 employees. I think we lost about 400 in this slide, but there are 8,400 employees. We have 2,000 physicians. We are #1 in operating margin in the state, which is no small feat at all. If you think about where we started in 2003, which was the time that I first came to Virtua, Rich said to me, we're going to build this huge hospital. The problem is, we are reporting a negative margin. We have never reported a negative margin before. That was our very, very first time. If you know anything about New Jersey, anybody here from New Jersey? Other than the people in the back. If you know anything about New Jersey, close to 50% of hospitals in New Jersey have a negative margin. So it's a very difficult state to actually make money. And even if you're making money, most of the time you're at about 1% or less than 2%. So our journey in terms of building this hospital and trying to perform at a level that's outstanding to be able to fund the hospital was a really daunting one, because we only had 80 days cash on hand when we were starting this. We had a negative margin, and I have a $700 million project at that point in time. We had to size it down so that it was not a combination of 3 hospitals, but instead it was going to be 1 hospital that would be about $480 million in cost. The STAR culture is very much embedded in our organization. We have a Governor's Award for Quality, top 3% in employee satisfaction. We were number one in the country for HR solutions for employee engagement and satisfaction, and we are on a Baldrige journey. We couldn't talk about agility and sustainability at Virtua, and we cannot talk about anything that we're doing without speaking the 3 component parts of what we do. Any discussion that we have focuses on strategy, process, and people. I'm going to speak a little bit more about our processes, because that is where the relationship is to what we're doing today. To the question related to readmission, in terms of adverse events and others, it's really important for me to emphasize to you that a new building doesn't yield that by itself. We have to have the processes already in place. So the new building, with all the different design elements required to do this, will really value add to what we were trying to do. This is our toolbox. This is something that we do constantly. Again, this is very familiar to you. If you look at component of change on the y-axis and complexity of change on the x-axis, it basically tells you, depending on how the size, cultural acceptance, process solution, and technical solution, these are the tools that we use. We are a very tools-based organization. Everything we do, anything that we plan for, must always have a presentation on what tools we're going to use. That is really critically important for us, because our measurements will be a function of that. The ability to scope the project appropriately, the ability to come up with performance and utilization management results will be a function of the tools that we use. If you look at the drivers for Virtua Hospital in terms of Voorhees as a replacement hospital, we knew that Voorhees was the capacity. The hospital that we have today is just about 1/3 of the hospital that we had before. An old hospital, although built in the 70s, not the most efficient, landlocked, and really quite congested. The spaces were very small with no ability to expand. There were many consumer preferences that we couldn't adapt to, and the reason for that is because we were constrained not only in design but also specification of that particular building. We were embarking on a $150 million investment in technology to make the hospitals digital. The question became, what's the affinity between that plan and the current space that we were working with? Very important for us to have an infrastructure that could be supported by digitalization that is appropriate, not only in interoperability, not only in terms of access of information, but also accuracy of the information. We had other technology that we wanted to adopt. We couldn't fit them into the building. The building was very, very tight. So the vision was the following, and I think Rich spoke to this quite eloquently. We focus on the patient, we focus on the clinicians, we focus on safety and the environment in which we would provide the care. We wanted to make sure that it is optimized or powered by good technology, and that the processes were repeatable and the findings generalizable in terms of our ability to replicate them. So that was really critical for us. Many of you that have built hospitals in the past know, or as we modify hospitals know, that many of the things that we do are based on the eyes of the clinician. What do the physicians want? What do the nurses want? The physicians sometimes, the patients sometimes are an afterthought. Although there's some musings about what they may need, it is not always center and upfront in terms of processes. So these are the guiding principles related to what we talked about. I'm not going to read through this because I pretty much spoke to you about this. Not only was this going to be a concept of quality and safety design, but it was also going to include patients. So the concept and the principle of inclusion was important. The inclusion not only of the patients, the inclusion of the clinicians, the inclusion of the physicians, and everybody who was going to reside and perform and work in that particular environment. In a little while, Mike will take you through the process of that in terms of what we've done other than the technical side of the whole planning for this particular place. These are the other guiding principles, again, speaking to the same things that I've spoken about earlier, as well as Richard spoken about earlier. So when you're looking at the other things didn't come in. What happened? There were other things in here, by the way. When you look at it from the eyes of the customer or the patient, it was really important to try to have a convergence model. What are the preferences? What are things that are important to physicians, clinicians, patients, and others? And how might we use a particular model like Lean to compose this particular model? I think it's a given that all work is a system. Every system is processes, and every time you have processes, there will be variability. So convergence was definitely important. But in trying to inform a plan, in putting this together, it was important for us to have a good understanding of what it is that we required. We saw a lot of hospitals, we visited a lot of places, but at the end of the day, there were certain things that we were not quite comfortable with. So it was important for us to look at what is empirical evidence out there, understanding what it is that we were looking for, looking at the qualitative side, looking at the quantitative side, but also equally important, looking at the intuitive side of this whole design. So how did we do the selection of the architect? We have some of the architects here, so I'm sure they can speak to this. We did things very different from the way others would have done it. We learned a lot from a lot of people. Many of us have had RFPs for architects in the past, but we decided that we would not do the traditional architect RFP. Instead, we would give them a problem or a specification and allow them to come back with us based on very specific principles, what it is that we might want. So there was specific input data. We also look at what the flow might look like. We look at different components related to the design of the place. We gave them very specific questions. We asked them to look at what would be the algorithm specific to this particular design. And when we did that, we had about 10 or 12 firms that responded. Or we sent it to, by the way, we sent it to about 10 firms. Only about 4 or 5 responded. So if you were looking at just one metric in terms of the selection process, this is how it rolled out, right? The first firm one said it would be about 10.8 million feet in terms of travel, in terms of algorithm and design. But there were 3 options that they suggested to us. The second one said it would be about 6.6 million feet. Firm 3 said about 12 million feet, double of firm 2. If you were just looking at pure numbers, it appears that firm 2 would be the most optimized one when you're looking at sizing. But at the end of the day, we actually went with firm 1, and I'll tell you the reason why. They gave us 3 different options. But equally important, we knew that we would bring our engineers in and use our process in terms of our toolbox to try to make this happen. They were the only ones that were willing to bring in their own engineer to work with our management engineer to model a lot of the algorithms, both clinical and non-clinical, that we were interested in. As a result, even if they were a little bit more than firm 2, we went to firm 1. And that was actually a good decision on our part. So now I give this to Mike for this specific design in terms of moving forward.
Well, firm 1 is actually here. So I know that they were breathing a big sigh of relief when Ninfa said it was a good decision. But firm 1 was HGA Architects, and Scott Limbaugh, who's our project architect, is actually in the middle of the room. This is your one chance to stand up and take some applause. Okay, I'm going to try to just scratch the surface about the process that we went through in terms of design. You're going to have the opportunity to meet the folks in the back of the room through panels and ultimately take a tour. And that's when you'll really be able to kind of hear more about it. Somebody asked the question earlier, do you think there was time wasted in the fact that it took 7 years? I think somebody over on this side of the room. The reality is we probably could have done this quicker, but I don't think we could have done it any better because we had the right people involved. I'm not going to go through all this slide, but the biggest difference I think was, as Ninfa talked about, the people who designed it and who are in this facility now and work here are the ones who actually did the design. Some of the things we did, this is an example of current state mapping. Our engineers are in the back of the room and could very thoroughly explain how we went through this. But again, this was done with our patients, by our employees and our management team. We also did, very early on, photojournals. We actually equipped our employees, some of our patients, with disposable cameras, and they walked around the existing facility and they took pictures and showed us what worked, what didn't work, and we turned over to Scott and his team a full volume of hundreds, literally, of binders that showed the things that really do and don't work in the facility. And if you're familiar at all with our old facility, there was a lot more that didn't work than did work. But again, this was right through the eyes of the customer. Oh, The Places You'll Go, it's one of my favorite books. We traveled all over the place. Now, we didn't have the opportunity to visit Florida or Hawaii in the springtime months. We had the privilege of going to Wisconsin, Minneapolis in January and February. So if you're familiar with that, you know how much fun that was. But the bottom line is, again, we took our users and the key folks to the whole process around the country, not only to look at overall facilities. We did model a lot of what we did here after a specific facility that HGA was building in Weston, Wisconsin, called St. Clair's. But we also traveled. We had teams that went all over. You'll hear about this in some of the other panel groups about specific things we looked at. Rich talked about private room NICUs. We spent a lot of time looking at different models for NICU, and our NICU team did that. But it was a variety of different purposes. In all, between conversations and actual visits, we probably talked to over 100 different other facilities. The other thing I will point out, at the time we were doing this, there was really no local other new hospitals being built. Following us, we actually have 2 more opening in this, within about a 50-mile radius. So we had to go to very kind of remote locations. I won't spend a lot of time on this slide, other than really as we went through the whole thing, Ninfa talked about the STAR, and this really just shows in each different component how we tried to marry that with the culture that we have. One of the things I do want to point out, there's a little bullet up in the top left that talks about minimizing the need for additional staff. And one of the things, and as other people have come in and talked to us, one of the things that I think really has made this successful is we had the same team operating the old facility and designing the new facility from top to bottom. We really didn't add any people, and it really created a vested interest all the way down throughout the organization. And aside from the, the nice paint job and the carpets and the great rooms, it's really led to a great sense of pride, I think, not only in the management team, but also with the employees. And I think that's one of the most critical pieces to success. Okay, so looking at master planning, Ninfa talked a little bit about the sizing exercises and how we went through that. One of the first things we did was really try to figure out kind of the overall massing and how the facility was going to operate. And we did this, as Ninfa talked about, with our management engineers. First off, trying to get, figure out how many beds we needed, really looking at some of those key principles, the guiding principles behind the design that we talked about in the beginning, and how we could incorporate them into different options. So we came up with multiple schemes, we graded them. Through our management engineers, we really tried to take a good look at what departments needed to be next to others based on the current state mapping, how patients flowed through, and also trying to drive waste for not only our employees, but also for patients as they enter the facility. We went through a very exhaustive evaluative process in terms of master plans. And at the end, we didn't pick any of the one individual schemes, but we actually combined a couple in a hybrid model. And this is just an example of the tool we used as we went through the process to really try to identify the strengths and weaknesses of each of those master plan designs. And again, you'll see at the top, really bringing it back to what drives this organization in terms of culture. We rated this by the points of the STAR and had a very diverse group involved in the ranking of this. So from an overall facility, some of the key things, and some of this is repetitive, you've heard it, access to natural light, you will see that throughout. As long as the sun's out, it's a great thing. August was a little rough here because we did get a lot of rain, but a lot of natural light. Private rooms, that was one of the key things initially. There is no semi-private rooms in this facility. We really wanted to maintain a distinct difference with our women's and children's population. This year we'll deliver about 5,600 babies, and that's a big part of what we do, so we really wanted to maintain the identity of that specialty. Somebody talked about, I think the previous presenter talked about flexibility. That was one of the things, as Rich talked about, we knew this initially was a consolidation plan, and it's not something we could do initially, but we knew we had to design the flexibility to accommodate that easily. So if and when we do get to the point of expansion, it looks like it was well thought out, and it really doesn't jeopardize any of the principles that went into the design. And obviously a better utilization of space. So this is Voorhees today. This is where you are, 680,000 square feet. We're all private rooms, 368 beds. And you'll get to see some of this throughout. As we went through different phases of the design, this really never changed once we locked into what the sizing needed to be, because we did it not based on necessarily what we could afford, but really based on what the community and what we thought our patients and our staff needed. Now I would love to explain this slide in detail for you, but that's what the management engineer team is here for. This is just an illustration of one of the tools we used. Once we knew kind of where the departments had to go, how they had to lay out next to one another, we really spent a lot of time, and Rich talked about it earlier, we had staff walking around with pedometers, we had them being shadowed by some of our management engineers. Really then, once we knew the size of the units, how are we going to make the units most efficient? And this is an example of looking at some of that travel within our neonatal intensive care unit, which really represented one of the biggest changes from our old design to the new design. And I can only show this because Rich isn't in this room, because he said he didn't want to see any more spaghetti diagrams. But this is an example of the spaghetti diagram for the pharmacy. This was the current state as they operated in the old facility, and how we tried to lean that out in terms of the new design. And again, we have plenty of experts who can explain this in gory detail for you if you're interested. But we duplicated this type of process in virtually every department to try to maintain as much discipline about how we were going to make this hospital efficient. The other thing we did, and Rich alluded to this, was the use of mock-up rooms. We built our first mock-up room, I guess, in the end of 2005. They started out, we had a little warehouse space in the old facility. They started as tape on the floor, quickly went to cardboard and on the walls and things like that. And ultimately, before we actually broke ground here, we had them finished to completion, the way they were going to look on this facility. Throughout that process, we invited focus groups of former patients, former family members. We brought hundreds and hundreds of staff, physicians, and managers through. We did mock codes and things like that. And a lot of that really led to, I think we probably changed those rooms about 20 to 25 times throughout the course of design. So when you look at, as you walk around, you're going to see some of these things. I won't read all of these slides. But a couple things that we really tried to maintain throughout was standardization where possible. And one of the ways we did that is our units, every unit in this portion of the facility, the bed tower, they're all 24 bed, basically standard units, some small modifications. The general layout is the same with the U shape, and you can maintain visual contact in a lot of different areas. In terms of support, it is decentralized, but we try to bring all of those, as Tejas likes to call them, the hunting and gathering points, as close to the clinician as possible, all with the idea of getting the clinician as close to the bedside as much of the time as possible. And some of the outcomes, and again, as I said before, and Laura, who's our quality director, is going to glare me down, because we don't have enough data yet to say this is a trend, but I can tell you the early returns being here is we are seeing in some of the metrics we look at related to patient safety and quality, we are seeing improvement. Core measures, some of those other things. Definitely the time spent looking for stuff generically has decreased, partially because of the design, partially because of the technology we brought in. We like to think it's decreased the fatigue, which is part of what leads to less errors. Some of our staff would argue after a walk from the parking lot. But for the most part, we think we've accommodated that. Decrease in sneaker time, same thing. And an increase in communication. And this was one of, as you walk around the units, this was a challenge for us because we no longer had that one centralized hub where all the communication activity could take place. That being said, I will tell you it was remarkable how quickly our physicians and staff adapted to that. And I think it's led to actually increase in communication. The single room NICU, you've heard a couple times, and I know we have a panel to talk about this. This represented one of our biggest changes from the old design. The hope was, and what we heard in some of the site visits, the private rooms would give a little more control back to the families, was one of the key indicators. It does use a pod design, very similar to what you'll see on the nursing units. And obviously, because it's a private room and it's private rooms and it's more spread out, we're much more dependent on technology in that unit. And Melissa, I'm sure, will tell you all about that. Throughout the facility, we have improved noise levels. We listed that under NICU, but you will notice we're not going to go to any in the tours occupied units today. But the difference in noise level between a full unit and some of the empty units you're going to see today is not great. That's been one of the biggest, most obvious advantages to the design. While short term, we have seen a decrease in length of stay, and you can see some of the other things that we are hoping will improve as we go down the pike here. In the emergency department, we really tried to create an emergency platform, so anyone who was coming to the hospital for anything emergent would kind of enter in the same general area. That's our C neighborhood, and that includes, we have two distinct emergency departments, one for adults, one for children. And we also added a distinct OB triage entrance where all of our pregnant, which is usually an emergent thing, entrance right around the same area, so everyone would come in through that dedicated platform. And again, looking for increased patient satisfaction, which we have seen. We're probably closer to be able to call our HCAHPS result a trend at this point than anything. We've been consistently, since we moved in the top about 13%, about 87 percentile. One of the other things, Rich talked about this a little bit, this was another big change for us, was our equipment depot. And what we did is transition from having everything that anyone could possibly need sitting in the hallways in the old facility to centralizing all of that. And we actually found a facility who was doing this as a byproduct of another site visit and really tried to incorporate it into the design. So we have space, it's actually on the 4th floor. They have a great view up there with the equipment. We put it there because it was the leanest location for it, cut the distance between 7 and 1. And now equipment is delivered on demand. It improves our ability to keep it clean. And with the RFID technology, we can find it really from any computer at any time. And lastly, the surgical intervention. Again, we tried to look at similar spaces and how do we better utilize that and maintain flexibility. So we took, in the past, we had dedicated separate units for short procedures, preoperative holding, stage 1 recovery, stage 2 recovery, kind of put them all in one general location to try to A, be flexible, and B, be more efficient. And you can see some of the outcomes we're hoping to achieve. And healing environments, you heard all about, when you'll see more about that as we go. So I'm going to turn it back to Ninfa to kind of wrap this portion up.
So how does this facility impact patient safety and also staff safety? Really, this is the core of your next 2 days. We found the following things in terms of observations. The number of handoffs between departments is less, which I think is much more optimized. The number of time for information exchange, other than the fact that we are now fueled by great technology, that was equally efficient. This is really great, the distance between patient move for services. When we were doing the spaghetti diagram and we were trying to do the tracker to see, we were absolutely surprised how much time the patient traveled. The patient's supposed to be stationary somewhere, except for the procedure, but they make up for that when they go to the diagnostic procedures. The degree of standardization for key care elements in the care environment. Again, understanding the right adjacencies. There are a couple of research studies that we did here, not only on sizing, but also adjacencies. I did the research study on sizing, and Tejas did a study on adjacencies. That was very enlightening to us in terms of what was traditional versus what would be the contemporary approach to both of them. The availability of the right tool at the right place and the right time. Again, access, access, access. so that there would be efficiency. Now, the process-driven facility design, which is what we call PDFD approach, has the following benefits. Again, quite great for us in terms of outcome. The cost of poor quality, the importance of getting it right the first time. Most of the time, the benchmark for change orders for any building is about 5%. Our change orders were only 0.3%, which is about $17.6 million savings for us. We do allocate around 5% for that to make sure that the change orders were accommodated. Having the mock rooms, having the simulation, getting into the mock room, getting the feedback, changing the variables, making sure that feedback to the simulation is adopted has been very, very important. Right sizing, if we're looking at a traditional approach, whatever the definition might be, against our PDFD approach, that's about $18.2 million in reduction or savings for us. Again, looking at the right sizing, the right algorithm, the right processes, and adjacencies, as well as sizing is very important. Better utilization of the space, about 100,000 square feet in savings. That's about $6.1 million. But this is the one that's really quite daunting for us when we started to track down what would be the distance that would have been saved in terms of miles per year for staff, patients, and families. That's about a reduction of 6,500 plus miles per year. When you think about that, that's really quite a lot, right? So again, what are the other benefits to this? The quietness of the room. When you look at our HCAP scores related to the quietness of the room and the quietness of the environment, you're seeing about the 90th percentile result. Significant improvement in clinical outcomes. Again, we have a couple of data points. We know that 1 or 2 data points do not make a trend. But beginning information tells us that antibiotic within 60 minutes is certainly there. TIA for stroke patient, discharge instructions, and reductions in falls. Again, we're going to have to do some comparative analysis between what is design specific and what is actually part of our process related to our toolbox. The 5 R's of medication administration, ED turnaround time, and staff satisfaction. But we are discounting the parking from that. Just kidding. I think it's already parked. They parked really, really quite far. So on May 22nd, we actually had to move. Some people were here at 3, some people were here at 4 a.m., some people came in at 6. At around 7:10 or 7:15, something around that time, I believe, I can't remember what time you called it, Mike called it and said, we're ready to move. 149 patients, a number of ambulances, 24 of them. Time duration, the total move of 149 patients was done in 3 hours and 47 minutes. When we were doing the simulation, just a little bit of story, when we started to look at whether we would bring a consultant or not for this process, I don't know how many of you have moved a hospital before, but that's quite expensive to plan. To bring a consultant in would have cost about $2.5 to $3 million to do. So our engineers at that time said, could we take a shot at it and see, give us a couple weeks. If we can't model it, then you can go to the outside. I'll tell you, when Mike and I looked at the first modeling session for this move, we were very, very, very impressed. And that's the reason why we stayed internal. Having said that, we don't usually use a lot of consultants anyway, but that was actually a very impressive moment for Virtua. Number of routes, red, blue, and yellow, it was coordinated accordingly. There were 3 exits that corresponded to the colors. And before the move, there were 3 tabletop drills and 3 more reviews. And it was really quite impressive. The changes, I was on the first one, and seeing what they ended up doing at the very end was really, really quite impressive. More importantly, other than the speed to execution in terms of the move, what was most impressive is everybody was safe, there were no problems, patients were in a good place, they felt very comfortable about the move. There's a lot of emotion that goes into it, but I will tell you, when you see clinicians, volunteers, and the like come together to move 149 patients, it's no longer about the prompts and circumstance. It's making sure that every life is safe, transported appropriately, tucked appropriately in the bed, and safe all the way. So with that, I think that would be the end of our presentation. I want to introduce, thank you. I want to introduce introduce the talent of this group. We get to present here, but we have incredible talent. I want to ask the engineers to stand up first, please. These are our managing engineers. May I ask the black belts to please stand up, please? And I'd like to ask the Voorhees team that makes all this happen to stand up, please. We're happy to, and I want to thank Mike. Mike is the leader of this group. Very, very impressive. Yes, sir.
When you evaluate your HCAP scores, do you have any kind of tools to tease out those scores that are simply the result of a new building, which would probably be very positive, versus actually trying to tease out the specific features that are the cause and effect relationship?
That's really a great question. Great question, because we have 4 hospitals. And we're seeing some changes in the score because of the peer methodology alone. Some that may be as a result of the new building. So what we are in the process of doing right now is trying to understand the confounding effects of all those variables to make sure that we could do a good root cause analysis. In fact, we just started that last week because we're seeing trend that predictably were not what we were expecting, and yet we were seeing trend that intuitively made sense. But we don't know if that's really a direct correlation and whether or not someday we can take on the road. Yes, ma'am.
Could you do, I guess, research on the cost of doing the mock-up changes, both in staff time, the whole list that you could look at it against your overall built-out savings and change order savings? If you did,
well, in terms of the cost of the actual going through that process, it was very minimal. I mean, even the mock-up rooms, we were bringing staff over to evaluate them during their shifts. I mean, they were just kind of walking through, giving us evaluations. So there really wasn't a lot of incremental cost there. We had some expense, just in terms of actually building what we were doing in the mock-up rooms. But, relative to where we ended up with change orders, and it's not, Ninfa talked about change orders. I can tell you moving in, that first month is really when you expect stuff to kind of shake out. We're all but through, about 3 months in, all of those changes. I mean, you see some digging out here, we're putting some lighting in. But the things that we were dealing with when we were moving in, there was nothing that was, really earth-shattering. And I think a lot of that goes to not only the mock-up changes, but the whole process.
It's a C-level argument that's very difficult to say, take more time, do this, and spend whatever the staff time and cost for the mock-ups is, versus get it in quick. So you have to say, what's the outcome? And if you got a significant value out of it, and lower change.
What's kind of interesting, and because we were doing, no, you're absolutely right, because you're going to be asked, how many people are going to use to do this, and what's the rate of return, and that's usually the question I ask for. One of the things that we were cognizant in the very beginning is that to immediately, while we were doing the simulation, what we were finding is what it is that we simulated and optimized in simulation was not the same feel that the staff had. Because when the staff started to feel it and walk it, where we put the bathrooms, where you put the faucets, they're saying, this is not going to work. This is not going to work. So because you really engage the staff into this exercise, one of the key things is make a decision at what point simulation is valued and when does feedback come in, and then you go for that. We had forgone a lot of the simulation optimized solution for what the staff was basically saying. And I think in part and in many ways, that's very helpful because today the staff owns it and they're not saying this is not going to work. They basically said this is what we wanted, this is where we're going, and this is how it's going to be, and they embrace the change. So for somebody like me that's constantly looking for return on investment, we really had to make sure we were tight on the dollars. We knew what the runaway cost might be for this, especially given the delay. We just really had to make sure that our processes were ironclad, that we felt comfortable with it, and more importantly, the staff input, when we said they're going to be involved, we had to involve. The rest, Mike had to manage and say, manage this in such a fashion that it's not a runaway horse.
Yeah, and just one other thing on the return side, we've managed to keep our ongoing operating costs relatively flat. And when you consider the facility is, relatively, I mean, it has gone up some, but when you consider the facility is 3 times the size, When you look at our adjusted cost per adjusted discharge or patient day, I think even Ninfa was surprised to see how we've been able to maintain that, and I think that's really in part due to, again, that involvement and getting that buy-in.
We can take one last question and then we'll have a break and panel discussion.
You can pick which one. We're not picking.
It's a very compelling story, and Sam, the STAR model that you spoke of seems like it's the AAA amplify. You've done a lot of planning ahead of time. I'm just curious though, has anybody done any look at, with anticipating a decreased average length of stay, decreased readmission, decreased revenues coming in the future? Was it ever a part of board discussion?
It wasn't necessarily a part of that discussion, but it is now a part of that discussion. So if you were looking at what we're doing today, we're calibrating what is the value index versus growth index. By value index, we're looking at the formula that looks like this. What is avoidable admission? What's the direct cost and length of stay associated with that avoidable admission? And what is the readmission rate? With the intent that we have to look for a different locus of care for the patients that are traditionally coming to the hospital. Very difficult when you have just built this new building. To that end, we have to be prepared that we may have a convergence model among our hospitals. If this is the right site that has the right algorithmic approach for care, and if in fact the wave of the future is that length of stay will go down, use of acute care will go away and become more transactional, as opposed to be an answer to all clinical issues, we could anticipate that we could turn into, on the south side, less than 3 hospitals today. And we embrace that, and we're prepared for that. What is key, however, is the ability to develop a locus of care outside of acute care so we can manage avoidable admission and readmission, so that care will be provided outside the traditional place, which is acute care. So while we were not thinking about it then, anticipatory-wise, we thought we really need to look at an ambulatory site different and apart from inpatient. That we thought was quite predictive on our part. We really didn't know how we were going to use it. So when it opens, when the ambulatory center opens, we will have total joint replacement that's being done in a hospital today, moved there on a 22 to 23 hour length of stay. So I think a lot of changes. The key for us is timing, to your question. When is the right time to pull the trigger? Because we have one foot on a different type of reimbursement and another foot that will be in a different type of reimbursement. So modeling serves us well, but also understanding needs of the patients, how they could be best met, looking at access, cost, quality, and experience.
Thanks, Mike and Ninfa. This was very informative.